Hello, everybody. Welcome. I hereby call the meeting of the Rotary Club of Colorado Springs to order. We will begin with the words of inspiration by Donna Dell'Olio.
Thank you, Kay. Kay just reminded me that I signed up for this. And I think it's probably a good thing that I didn't plan something because something's been on my heart and it'll give me a chance to say it. We get to make so many choices in our lives. We're so fortunate that we get to choose so many things, what we get to do. And I read something a few years ago by a person some of you might know who immigrated from Vietnam. And it just caught me. Nobody chooses to be a refugee. And I don't intend that in a political way at all. I know I've said something like that to people that have sat with me at Rotary. And Stan Mitage, who I loved, who said, Donna, we can't just let everybody come into the country. And I know that. I don't intend it to be political, but I think it's something that we should remember and be so grateful for our choices. And we get to choose to volunteer, so later Kay's going to let me talk about reading. But that's all I have to say. Thanks.
Thank you, Donna. And then if you would join me in the Pledge of Allegiance. Okay. I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
And then please join me in the four-way test. In everything we think, say, or do, is it the truth? Is it fair to all concerned? Will it build goodwill and better friendships? Will it be beneficial to all concerned? And now, if you guys remember Alvin and the Chipmunks, we're going to sing a song about a doctor. I thought it would be appropriate. So we're going to sing The Witch Doctor. So I hope you'll all remember and join me.
My friend the witch doctor, he told me what you said.
I told the witch doctor I was in love with you. I told the witch doctor I was in love with you. And then the witch doctor, he told me what...
Technical difficulty.
Just best to rhyme.
How about God bless America?
Otherwise, we'll let Trevor lead us.
I don't think I know all the words. I think I know the chorus.
I told the witch doctor I was in love with you.
Here's some words. Here we go.
Ooh ee ooh ah ting tang walla bing bang. Ooh ee ooh ah ting tang walla bing bang. There you go.
I told the witch doctor I was in love with you. I told the witch doctor I was... I told the witch doctor I was in love with you. I told the witch doctor I was in love with you. And then the witch doctor, he told me what to do. He said that... I told the witch doctor you didn't love me true. I told the witch doctor you didn't love me nice. And then the witch doctor he gave me this advice. He said that ooh ee ooh ah ah ting tang walla walla bing bang. Ooh ee ooh ah ah ting tang walla walla bing bang. Ooh ee ooh ah ah ting tang walla walla bing bang. Ooh ee ooh ah ah ting tang walla walla bing bang. You can keep your love from me treat just like you were a miser. And I'll admit I wasn't very smart.
Thank you.
So I went out and found myself a
Thank you very much. Regression to when we were kids. I now, please enjoy your lunch. And while we're eating lunch, we'll have a video play about the Rotary Peace Corps partnership. We heard about this at our World Peace and Understanding Luncheon last year, or earlier this year, so you should be familiar, but you can watch that while we're eating lunch. And enjoy.
Yes.
In 2014, Rotary General Secretary John Hugo and Peace Corps Director Carrie Hessler-Radlett signed a memorandum of understanding to promote their shared mission of service and sustainable community development. Those leaders understood that Rotary and Peace Corps areas of focus virtually mirror one another. The MOU was signed as I began my service in Peace Corps, Georgia. Unaware of the global agreement, I connected with Rotary in Tbilisi. It just seemed logical. Partnering for Peace is an all-volunteer nonprofit organization built to support the Peace Corps relationship through awareness, education, and outreach. Joint projects have included library shelves in Peace Corps volunteers' villages, health screenings, vocational training, conflict resolution training, providing microloans, and joining together for WASH projects, etc. One of our RPCV members even ran an International Rotary Youth Leadership Awards, or RYLA, conference in Ukraine, being run from the U.S. during the pandemic. Our website documents over $1 million in joint projects. The war in Ukraine quickly brought Rotary and Return Peace Corps volunteers, known as RPCVs, together to aid Ukrainian citizens and refugees. Members have supported funding and assisted on the ground coordinating with RPCV affiliate groups and Rotary clubs worldwide. Fundraisers, donations, Rotary grants, disaster response grants, and local on-the-ground support are now the norm.
What are the three goals of Peace Corps?
Well, as you mentioned, President John F. Kennedy founded the Peace Corps 60 years ago to promote world peace and friendship, which is a very, very lofty and ambitious goal. And, I often say that world peace and friendship is not just the work of politicians or of governments, it's the work of individuals around the world coming together across difference. So in the Peace Corps Act, the three goals of the Peace Corps are: first, to help the people of interested countries in meeting their need for trained individuals. So it's a developmental goal and really based on those requests that come in from countries that ask for our support. Second, we help promote a better understanding of Americans on the part of the people we're serving, and we help promote a better understanding of other people on the part of Americans. So essentially, it is a cross-cultural exchange, bridging divides and overcoming differences as we work together side by side. Volunteers go out at the invitation of foreign governments, and they go into local communities and they work on locally identified priorities and really share the diversity of America. So it is very much an organization that is based on cross-cultural respect, deep partnership, and really working together on those issues that are most challenging.
Well, I think there's really, if you look at the missions of Rotary and Peace Corps, they overlap tremendously. The concept of making the world a better place, enhancing goodwill, fostering international understanding, developing concrete programs and projects in country that are really making a difference in people's lives. That's what Peace Corps volunteers do, and that's what Rotarians do. And that's why I'm personally so excited about this partnership that we have, because I think we bring to bear the strengths of two incredible organizations to truly make a difference in the world. I think with the active Peace Corps volunteers in the field, the tremendous synergy with what Rotary clubs are doing on the ground. The Peace Corps volunteers, the active ones, bring local contacts and sort of community development insights. Rotarians will bring financial resources, people power to these projects. So I think in the field, tremendous scope for Rotarians and active Peace Corps volunteers to collaborate. And if we're talking about sort of returned Peace Corps volunteers, of course they always maintain their relationships with their host community and are sort of perfect Rotarians to come back to their home countries, join a Rotary clubs, continue to leverage the relationships they have in the countries where they serve. So I think it's sort of a marriage made in heaven, and we really look forward to sort of taking that relationship and continuing to expand it.
Very true. Carol, how do you view this?
Well, I couldn't have said it better than John just did. There is so much potential to work together. Rotarians bring tremendous diversity of experience, resources, and as Peace Corps Week, comes up, it's highlighting just how many returned volunteers are active with Rotary and are still active in their communities, doing work overseas and in their communities here. It's a natural partnership of service-minded organizations.
Okay, I know it's so much fun talking at your tables, but we need to get moving on our meeting. We have lots to cover today, so I appreciate your attention. First of all, I'd like to introduce Kurt Orman, who will introduce our guests and visitors. Yeah, I know that guy.
Welcome, everybody. Glad you're here. Great day. Everybody's having a lot of good times here, and I have a story for you. Guy was walking down the street of Colorado Springs, and he comes upon a house that says, "Talking dog for sale." And son of a gun, the dog was right in front of him. He said, well, might as well stop and chat with him a minute or something and see if this is true. So he says, "Mr. Dog, where have you been in your life that you can tell us about?" He says, "Well, first of all, I was a rescue dog in the Alps and could help out over there. And then secondly, I joined the Army and I was a dog sniffing guy for bombs, a sniffing dog bomb, what the hell that is." And thirdly, now I've sort of retired, but what I do is I read to older folks who have poor vision. Guy was amazed. And so he went up to the door, and just as he got to the door, the owner comes out and he says, "Yes?" He said, "Well, I just met your dog, and why are you getting rid of a magic, great dog like that?" And he says, "That dog's a damn liar. He never did that damn thing like that." Oh, wasn't that good, I guess. Well, we have a couple of visitors here, and Dwight, where are you sitting, buddy? And you want to introduce your junior?
Thank you. Here you go. My son, Here you go. This is my son, Dwight Jr. He's just moved here from Victorville, California, where he was a member of the Victorville Rotary Club for almost 26 years.
Yay.
And president of the club for 2 years. So he's one whale of an enthusiastic, encouraging young man, and we're glad to have him here because I guess he passed all the deals that Karen threw at him. So he's joined the Salem Media radio company that owns 99 Christian radio stations in the United States. 3 of them are here in Colorado Springs. So he's been in radio sales for 36 years, and he knows the business pretty well.
Give that microphone to Dwight Jr.
There he is.
No, Dwight Jr.
Thank you.
Is this mic on?
You want to say anything?
No, you said it.
Okay, Dwight, we'll look forward to seeing you. This baby doesn't sound like it's on. It is on, okay. Let's see. Alan, where are you, buddy? There you are back there. You want to introduce that nice woman beside you?
Yeah, my guest is my wife, Jan Weiland. She heard that we were going to be learning about strokes, so she decided to come along, see if I'd already had one.
That's a stroke of luck. Bad. Okay, let's see. Melissa Hoffman is going to be introduced by Trevor.
So Melissa Hoffman is with the Colorado Springs Fire Department, and she is part of their wildfire mitigation team. She actually goes up and fights wildfires, but she's going to be talking about FireWise, which is the city's plan, or the fire department's plan, to just help keep your house safe and keep you educated on what to do there. And then certainly we've got John Scott here as my guest. I'll introduce him when he goes up to speak. Thank you, Melissa, for being here. She's very happy to be here.
All right, Melissa Weiland. All right. Hoffman, Melissa Hoffman. And now let's give a hand to our president. She's done a great job in a bunch of things. Get her on here. Come
Thanks,
on.
Kurt.
Come on.
Okay, next on the agenda, we're going to recognize our birthdays. We have a couple, and some of them are here. Jody Ritchie, happy birthday. And Amanda Salmons and David Brockaway. I think he's here too. Yay, happy birthday. And then Rotary anniversaries. Hard to believe, Chip Frazier is only 2 years. He's so involved and active. So can't imagine how we did without you. Kent Felice is 3 years. Randy Stiles, another fairly newbie, 4 years, and he jumped in with both feet as well. Thank you. And George Reed is celebrating his 20th year as a Rotarian. Thank you so much, George, for all you've done. And then I'd like to recognize those who've helped at the meeting today. Cashier Charlie Brown, registration Chris Lewis, greeter Misty Stewart, greeter Chip Frazier, words of inspiration Donna Dell'Olio, visitor check-in and guest introductions Kurt Ormond. And so thank you very much. And now I'd like to recognize Tina Dewey to talk about Flight, which is next Saturday. I hope you're all as excited as I am. And let's get an update.
Hi, everyone. So as Kay said, next Saturday is Flight, and we need to give a head count to the Boot Barn by Monday at noon. So we are hoping, if you're planning on coming, that you purchase a ticket this weekend so we can get an accurate head count. Also, if you're a sponsor, I have your name already entered into the GiveSmart system, and you just need to show up and check in with reception, and you'll be good to go. And then lastly, we are still needing help with movement at the event itself, moving the butterflies around as they're being auctioned off. We're looking for some young people to help us. If you'd like to volunteer yourself or your children or anybody you might know, please get in contact with me. Okay, that's it. Thanks.
And then also we want to remind you, this is the first time we are auctioning off something other than garden-sized art as part of our live auction. It's kind of a new thing. And so Vita's here to talk about that.
Hello, everybody. So yes, there's some flyers on your table, and there is it's a trip to a place called Casa Piazza at La Punta, and it is in Manzanillo, which is in Colima, Mexico, which is south of Puerto Vallarta. It is a 5-bedroom, 5-bath-and-a-half house. It comes fully staffed with a cook and staff to make sure that you're well taken care of. It has a palapa up on top with a hot tub. It has a pool on the main level where the staff takes great care of you. When I was there, we had unlimited margaritas all day. It was not a bad place to stay. Get 4 couples that want to go with you and your wife, or it also suits 2 families of a total of 12. If you guys have ever seen the movie 10, there's a private beach that you will get to spend a day at. That is where they filmed the movie that Bo Derek ran on. It's not a bad place to stay. Danny DeVito has stayed there. I can't say enough about how it has an airport that you fly directly into, so you can fly directly from Denver into the Manzanillo airport. So travel is very, very easy there. There's a house person that picks you up and takes you to the home. It's in a gated community. You're very safe. It's very lovely. If you want to know more about it, come and talk to me. But this is a fantastic trip. So tell your friends. There you go. Thanks.
Thank you very much. It sounds very exciting and a special vacation. Now I'd like to recognize John Kaufman to talk about some of our international service projects.
Thank you. A lot of you know that we have a Kenya trip coming up in October 23rd to November 4th. And this is 2 Maasai villages. We're putting in water purification systems there. We're going to be doing 1,000 eyeglass fittings we got foster grant readers in different powers. and we're going to be putting in 2 computer labs. And these are opportunities for, I call it service, soul, and safari, because we'll also be checking out the Great Migration, which is going on at the same time. So if you're interested, let me know. I'll give you a registration package that you can take a look at, and we'd love to have you. That project, about $80,000, was funded by a new form of funding, international and domestic for that matter, projects, called program-related investments. And that was all provided by the Prior Lake Rotary Club Foundation. Their newest member is an old member of the Colorado Springs Rotary Club, Michael Thomas? Michael Thomas, who was the school superintendent. He in D11, he moved to Prior Lake and joined the Rotary Club up there. So just a happy coincidence. Finally, I'll wrap up with where I was last week, why I wasn't at Rotary last week. I was at a conference of the zone district governors for the Big West. And this was a presentation about water. I was the keynote speaker. I was talking about these program-related investments and this new opportunity for new kinds of funding. And I was followed by the other keynote speaker, which is a guy named Captain Paul Watson. If the name doesn't ring a bell, you'll know the organization he founded, which was Greenpeace back in the 70s. He is the Save the Whales guys. He's the guy who would take his ship, the Sea Shepherd, and ram harpoon ships to prevent them, and he'd get in between them and shooting the whales. This is the craziest guy now. He's very old. He looks like Hemingway in a nursing home. And he didn't realize why he was there. He was telling great stories. And I spoke first, and then he spoke. So as we're passing, he says, "Oh, this is a Rotary meeting?" And I said, "Oh." So at least he knew that it was a Rotary meeting because I represented Rotary, folks. All right. Thank you.
Thank you so much, John, and the International Committee. We've got some great projects this year. Very excited. Now I'd like to introduce Donna Del Olio, who will talk about our reading program. Yay!
So one of our club service projects, and my personal favorite, is reading with second and third graders. We started at Audubon Elementary School last year, and we got cut off a little bit because of Omicron, but 6 of us continued to read, and it was a bit of a struggle because the teachers were concerned that letting these kids out of the classroom for 20 minutes a week would impair their learning. Well, after reading with after the experience, we are welcome back, and they want more of us there. The connections, I think anyone that read last year will tell you, the connections we formed with these kids were just great. And I promise you that if you volunteer to read this year, it'll be the happiest 30 minutes of your week, and it'll just the kids love to see us, and they benefit so much from having a relationship with a Rotarian. So I have forums that I'm going to keep announcing for a couple of weeks because we seem to get different people at our meetings, but we would love to have you participate in this opportunity. You read once a week. We have 4 time slots this year, so you read on a Tuesday or Wednesday. It's a morning or afternoon time slot. It's a second or third grader. We're going to start the week of October 11th, and we get trained the week before. And it doesn't take any special skill. Really, the important thing is that you show up for the kid and that you're consistent and you're there, and it gets them. It makes them just happy about reading and reinforces the importance. How important they are and how important reading is. So I hope I've got forms, and your spouse, or in Chip's case, mother, can do this through our club. So it doesn't have to be you. Think of somebody in your family that would like to do this. Yes.
I did this last year or last semester. It's 30 minutes a week. At first, you're going to think that that kid thinks you hung the moon. When you get done with it, you'll realize that they hung the moon. It's much more than reading, so please do it.
Thanks, Chip.
Thank you, and I did it as well, and you really bond with the student that you're working with, and you get to be another positive influence in their lives. So if you have time, it's a great project. There is information on the tables regarding our upcoming events, and again, flight. Get your tickets and get your raffle tickets in. And now I'd like to recognize Trevor to introduce our program for today.
So this guy and I went to high school together. We were in student council together. I was senior class president the year that he was junior class president. So I know he looks 10 years younger than me, but it's really just about one. No, we connected when he moved to Colorado Springs recently, and he's a smart guy with good information to share. So I'm just really excited to have you welcome Dr. John Scott to our Rotary meeting. The words are right here. Ooh, Is
that on? Is it on? Yes. Okay. Well, thanks for that introduction, Trevor. And like Trevor said, we did go to high school together. This was we both grew up in Northern California area. Let me just get this clip on here real quick. Put in the pocket. So when I moved to the college, we had kept in touch via Facebook and whatnot, and when I moved down here, I got in touch with Trevor. And as I was preparing this talk in my office, I saw a couple of yearbooks up there, and I thought, I wonder if, and sure enough, here's Trevor on the left, Ponderosa High School, class of 1990. He was voted most spirited, and I think that suits him well. Most spirited. And there is me looking kind of confused and not knowing what's going on. But so we've known each other.
You're about 5'3" then too.
Yeah, I grew a little bit, but we've known each other for over 30 years, and so I appreciate Trevor asking me to come in and talk. And so I don't have the talk memorized, so I apologize if I'm looking back over here. I did prepare it myself. I've given this talk or similar talks in the past. Usually I'm giving them to medical communities, fellow doctors and nurses and things like that. And so if I tried to kind of make this more conducive to the general public. If you have a question, just shout it out or raise your hand. I think we can ask questions during the presentation. I just want to make sure that everything's clear. I'm here for you to talk about this. My background is in neurology, so I went to medical school at Ohio State University. I came out here for residency at the University of Colorado, and I stuck around and did a fellowship in vascular neurology. So my specialty is stroke. Now, as a neurologist, I treat all neurological conditions, Alzheimer's disease, multiple sclerosis, epilepsy, Parkinson's disease. But my extra special training is in stroke. And for several years, I would do about half clinic, half hospital time. And then more recently, I switched to working just primarily in the hospital. I work at Penrose Hospital and St. Francis Hospital. I started here at the beginning of the year from the Denver area, and I'd been up there for many years. And then I work in the hospital taking care of inpatient neurology conditions, primarily of which is stroke, but of course I see all neurological conditions that are admitted to the hospital. And so I'm going to talk about stroke, and so that's what my focus is going to be on. And the goal of my talk today is going to be to have the ability to recognize the signs and symptoms of a stroke, know what to do if you suspect someone is having a stroke, and third, if necessary, commit to making change in your life that will help prevent you or someone you love from having a stroke. So the vast majority of patients that I see are patients that come into the hospital have suffered a stroke or a small stroke or a TIA or something like that. Never has anybody made an appointment to come see me and say, hey, how can I prevent a stroke? And so all of these tips and things that I talk about patients with on ways to prevent strokes, they're for patients that have already had stroke. And so if you haven't had a stroke and there are some changes that need to be made in your life, now's the time to do it because strokes are preventable. So why do we care about strokes? Well, strokes are very common. I think probably everybody in this room has been affected by a family member, a friend, a colleague, or somebody that has had a stroke. And in fact, nearly 800,000 people in the United States have a stroke every year, so quite common. Every 40 seconds in the United States, somebody has a stroke. Every 3.5 minutes in the United States, somebody dies from a stroke. Now, stroke-related costs in the United States came to nearly $53 billion. That was a few years ago, 5 years ago, between 2017 and 2018. So $53 billion. Imagine how many student loans we could forgive with $53 billion. You know, a lot of money spent there. So why do we care about strokes? Second leading cause of death worldwide. Annual mortality rate of about 5.5 million, and is the leading cause of disability in adults. And so I think the most devastating strokes that we see are strokes that don't cause death, but they cause severe disability where patients can't go home. They have to have 24-hour care. They live in a nursing home. They can't enjoy the activities in their life that they want to enjoy. And so those are the most severe effects of the stroke. And not only does it affect the person who suffered the stroke, but it also affects their loved ones, their care providers, their family, who is having to make changes to their life to care for this individual who's suffered a stroke. And so it can be devastating, not only to the patients, but to the families and to the community. So it is a huge public health issue. And about 80% of strokes are preventable. So the vast majority of strokes can be prevented with the proper care. And so that's kind of what we're going to talk a little bit about today. We're going to talk about what is a stroke, how do we treat acute strokes, and then what are some of the things that we can all do to prevent strokes. So really a stroke happens when blood flow to the brain is disrupted. So of course blood flow supplies the oxygen to the brain. And if you have blockage to an artery, that blocks the blood flow to the brain, we call that an ischemic stroke. And now, if you have a ruptured blood vessel, we call that a hemorrhagic stroke. And so strokes are primarily broken down into those two categories. Ischemic stroke, which is blockage of blood flow, lack of oxygen, and then hemorrhagic strokes, which is a ruptured blood vessel, a hemorrhagic stroke. And then you may have heard the term mini stroke, or TIA, stands for transient ischemic attack. Sometimes people refer to it as a mini stroke, but it's basically temporary stroke symptoms that can last only a few minutes but doesn't cause permanent damage. And so a TIA can be an indicator that someone's at risk for having a stroke. So patients begin to have a stroke, but their body is able to kind of clear up that blood clot or whatnot and restore blood flow to the brain. So those are kind of the three strokes that we talk about: ischemic stroke, hemorrhagic stroke, and a TIA, or sometimes called a mini stroke. So just another little a diagram here, a little cartoon. On the left, the ischemic stroke. A blood clot has formed in the artery in the brain. The blood clots can form due to atherosclerosis in the neck. They can cause a blood clot there. They can break off. The blood vessel itself can completely clot off. Sometimes patients will develop blood clots in their heart from irregular heartbeats like atrial fibrillation or a valvular heart disease or something like that, and the blood clot will travel up to the brain. That blood clot, or we call thrombus, will block off blood flow to part of the brain. On the right, you see a ruptured blood vessel there. That you can have the artery itself rupture, or you can have an aneurysm, which is an outpouching of the artery. The aneurysm will rupture. When that aneurysm ruptures, we call that a subarachnoid hemorrhage. And so Ischemic strokes are the vast majority of strokes. About 87% of strokes are ischemic strokes, and about 13% are hemorrhagic strokes. Well, the good news is that the actual incidence of stroke is actually slightly declining, and I think that goes to show that we are doing a better job at controlling stroke risk factors nationwide and access to health care, but not in all populations. And you can see this diagram on the right. That kind of southeastern United States is kind of what we refer to as the stroke belt, very high incidence of strokes. So the risk of having a stroke is nearly twice as high for blacks as it is for whites. The black community also has the highest risk of death due to strokes. And in some cases, we're actually seeing the rates of death increase in strokes in the Hispanic population. Now, age is a big risk factor. As we get older, our risk for stroke goes up, but anybody can have strokes. I've seen strokes in as small as children. So at any age, patients can have strokes. Typically, the mechanisms are different, but strokes can affect any age. So let's talk about the signs and the symptoms of a stroke. Now, this is important for everybody to know because we are all going to be the ones out in the community that are expected to recognize the signs and symptoms of a stroke. So here's just, they've created, I think it was the American Heart Association that created this acronym, FAST, F-A-S-T, face, arm, speech, and time. So what are the signs? Sudden numbness or weakness in the face, arm, or leg, especially on one side of the body. Sudden confusion or trouble speaking, difficulty understanding speech. Sudden trouble seeing in one or both eyes. Sudden trouble walking, dizziness, loss of balance, or a lack of coordination. Sudden severe headaches with no known cause. So once again, sudden. So strokes happen suddenly. They don't happen over 6 months or over 2 years. They happen suddenly within a matter of instantaneously or a matter of a few minutes. But really any neurological symptom, the brain controls the functions of the entire body. So any neurological symptom, numbness, weakness, dizziness, vision loss, incoordination, it can be the symptom of a stroke. So they've developed this fast, kind of a layman's ability to recognize a stroke. Face, so ask somebody, smile, you're looking for full facial droop on one side of the body. Arm weakness, ask the patient to raise their arms. They may have droop to one side of their arm, or they may just have numbness to one side of their body. Speech difficulty, is their speech slurred, or are they actually not able to get the words out, or they're just talking gibberish? We call that aphasia. That's a common symptom in stroke. And then T is time to call 911. So if you suspect somebody is having a stroke, it's important to seek emergent medical attention. You don't want to wait, let's see if it kind of gets better, that sort of thing. Another acronym is BFAST, and so they just added a couple more symptoms. Balance, sudden loss of incoordination or balance, so sudden onset of vertigo or dizziness or stumbling around. Eyes, sudden loss of vision. You may have loss of vision in one eye, or what we'll see is loss of vision in both eyes to one side of the vision field. So patients, they can see everything to the left, so the left eye will see to the left, the right eye will see to the left, but they can't see anything to the right, or vice versa. So sudden onset of vision loss to one side. Once again, facial numbness or facial weakness, arm or leg weakness, speech difficulty, time. So these are just sudden onset of neurological symptoms is the hallmark of a stroke. So how are strokes treated? And so the biggest obstacle to diagnosing a stroke is actually recognizing a stroke. It's not uncommon that patients will come into the hospital. This doesn't happen frequently. Patients will come to the hospital, and for a symptom, they got kind of confused or they were dizzy. And then 2 or 3 days go by, and there's still those kind of symptoms. The last meeting involved and say, well, they had a stroke 2 or 3 days ago. So it's not uncommon that even medical professionals misdiagnose these strokes. But it begins the moment that EMS is identified. So Melissa from the fire department here, she works on EMS as well, and so she probably takes care of a lot of these patients. So what happens is, if you're at home and you expect you're having a stroke, or you suspect somebody else is having a stroke, you call 911. 911 sends out paramedics out there. They assess the situation, and they have their tests. They do very kind of similar kind of things: face, arm, a weakness, speech difficulty, numbness. And they say they have a kind of a grading scale, and they'll say, you know what, this looks like a stroke. And so they'll actually activate a stroke alert. So they'll take the patients to the hospital, they'll call ahead, and they say, we have a stroke alert coming in, these are the situation. This is, a 65-year-old gentleman, and these are the symptoms, and we're concerned he's having a stroke. So patients that are taken via EMS often get diagnosed more quickly and more accurately. They get the hospital kind of prepares for them to come. They notify the stroke team, which includes myself, the stroke coordinator, the ER physician, the ER staff. They clear out the CT scanner. Those patients get wheeled in. While they're walking into the CT scanner, we're examining these patients and trying to identify what's going on. And so a lot of times, even about a third of patients that are having a stroke decide to drive themselves in or have family members coming in and things like that, or maybe they don't recognize that they're having a stroke. But they get much quicker and much more aggressive care when EMS is involved in that care. So it's important to call 911. So once again, EMS will call the hospital ahead of time. They will activate the stroke alert that includes myself, the ER physician, the stroke coordinator. CT scan is cleared out, and we're kind of waiting for the patient to arrive, typically, and we're evaluating the patient as they're being wheeled off in the CT scan. We're trying to figure out what's going on for this patient. We also have the ability to, I don't stay at the hospital for 24 hours a day, but we do have tele cameras, and so we'll actually evaluate these patients remotely. And so it's not uncommon that I'll get a stroke alert at 2 o'clock in the morning, and I'm at home, I'll log on the camera, I'm evaluating this patient along with the ER physician, and we're making treatment decisions together. So that's one of the ways that stroke treatment has improved or progressed. Now, not all patients who have stroke symptoms are having a stroke, and in fact, even in the hospital setting, when patients come into the hospital for stroke alerts, only about half of those patients actually end up having a stroke. So there's a lot of other conditions that will cause stroke-like symptoms that are not stroke. What are some of those? Migraine. Migraine actually causes a lot of stroke-like symptoms: numbness, weakness, speech difficulties, headache. A seizure can cause stroke-like symptoms. Metabolic disorders such as low blood sugar, low sodium, liver disease, really any kind of metabolic derangement can provoke stroke-like symptoms. An infection or sepsis, a brain tumor can cause stroke-like symptoms. Bell's palsy, facial droop, we see that quite frequently. Passing out, transient global amnesia, which is a fascinating disorder. If anybody's ever suffered from that, but they just suddenly lose short-term memory for just a matter of hours typically. But any drug or alcohol intoxication, peripheral vertigo from the inner ear, or functional disorder. Sometimes patients feel like they're having a stroke, but they're not. And so it's really my role and the ER physician's role to try to figure out within a matter of a few minutes, is this a stroke, and what is the best way to treat it. And so we're kind of running around with our heads cut off trying to figure this out in just the very first few minutes. So patients will come in, we'll take them directly to the CAT scanner. So if you've had a CAT scan before, they're very quick. They're 15, 30 seconds. There's really virtually no contraindications to CAT scan, so anybody can get a CAT scan. And you'll see pictures up here. On the left is a CT scan of an ischemic stroke. Like all x-rays, the CT scan is reversed. So this is actually a right hemispheric stroke. You can see this large area. This is not an acute stroke. This is probably 4 or 5 days old. There's already changes to the brain that are going on. You're seeing swelling. On the right side there, in the middle picture, that is a hemorrhagic stroke. So an ischemic stroke, lack of blood flow, and then on a CAT scan, acute blood looks bright. So this is a hemispheric, or a right hemispheric intracerebral hemorrhage in the middle. And then on the far right, that's actually a subarachnoid hemorrhage from a ruptured aneurysm. Okay. Typically, patients that are having an acute stroke within the first 2 or 3 hours, the CAT scan is actually going to look normal. And so these changes that you're seeing here with this ischemic stroke typically it was just going to look normal. It takes time for ischemic strokes to actually show up on CAT scan. So when patients come in with an acute stroke, we do a CAT scan and it looks normal. It doesn't say they're not having a stroke. It means they're not having a hemorrhagic stroke, but it still very likely could be an ischemic stroke because it takes time for that stroke to develop on the CAT scan. So here are some other imaging techniques that we use. So the top, this is all the same patient. On the top, we see a CAT scan, okay, and you can see how that CAT scan looks completely normal. But the bottom two screens are an MRI, or the bottom two slices here are an MRI. And you can see that right hemispheric stroke, once again, it's reversed. So that right hemispheric stroke is what's shining bright on the MRI. So MRI will show an acute ischemic stroke very, very quickly. But MRIs, there's a lot more contraindications to getting MRIs. Metal in your body and things like that. They take much more time to do. MRI typically takes 30 to 45 minutes to do an MRI. It's much more claustrophobic. And so if you're trying to figure out this is an acute stroke, MRI is not frequently used. It's typically just the CAT scan. On the right here, you see, once again, there's a intracerebral hemorrhage there on the right. That's a CAT scan on the right, and it looks similar to the ischemic stroke on the MRI. So just different imaging techniques that we can utilize to identify an acute stroke and what's going on. And now we have some more advanced imaging that we're using. These are called CT perfusion scans. And so here on the left, you see in the top left corner, you see just a non-contrast enhanced CAT scan. It looks essentially normal. But then on the image B on the bottom left, it's a CT angiogram. And you see this blood vessel right where the arrow is pointing. That's the left middle cerebral artery. And you can see a blockage to that artery right there. And so this is a CT angiogram. We give contrast so you can see blockage. And then we can also do perfusion scanning where we give contrast and we can time how long it takes that contrast to reach that portion of the brain. And so even though in picture number A, the CAT scan looks normal, the CT perfusion scan, you can see in E, F, and G there is significant delayed blood flow to that part of the brain, so delayed perfusion, okay? Here on the top left, you see, top right, you see another CT angiogram with a left and middle cerebral artery occlusion. You can see it from the axial and the coronal vision. So this is almost like we're just sitting on top of the patient. The other one's looking at it forward, and you can see that blockage of the artery. So a lot of different imaging techniques that we can use. So when we're evaluating the patient, we're talking with the ER physician, we're deciding together, okay, what imaging do we want to do? Do we want to do a CT scan? Do we want to do a CT angiogram, CT perfusion scan? Do we want to do all of them? Do we want to do just a CT and a CT perfusion? So these are the things that we're deciding very quickly to figure out what to do. Some of the other ways that imaging techniques are advancing. This is also a CT perfusion scan, but you can see the app on the phone. This is a program called Rapid, and we have it on our phones, and we use it at the hospital. It actually bypasses it. The CT scan will be done, and it gets uploaded immediately to our phones, and we can look at it immediately, even before the radiologist gets it on their computers. And so it gives us the ability to be scanning. And so I'm getting alerts, there's an abnormal CT perfusion scan. It will look for, through artificial intelligence, look for evidence of a large vessel occlusion. So just using technology to further aid in the diagnosis of strokes. So it's basically having the ability to view these images, almost immediately when they're done. So when I'm at home at 1 o'clock in the morning, I see the patient, via the camera, talking with the ER physician. They do the scan. It comes right up on my phone. We're looking at it. We're making these decisions on what to do to treat the patient. Another form of imaging that we can use is called cerebral angiography. So this is a more comprehensive imaging where our radiologists will actually take a catheter and insert it into the femoral artery and guide that all the way up to the arteries in the brain and then inject contrast. And you can see this beautiful picture of all of the arteries here. You have a carotid artery going up, and you see, these are the eyes over here, there's the back of the head, and you can see all of the arteries in the brain. Here we're looking at a different angle, but you can actually see this blocked artery. There you have a left internal carotid artery coming up, and you can see that left middle cerebral artery is blocked. And so this is kind of the gold standard for imaging. So how were strokes treated? Well, before 1996, there was really no approved medication to treat strokes, but in 1996, this medication was approved called Alteplase, also called TPA, just another name for it. Alteplase is the brand name, but TPA is the name the chemical name. It's actually a chemical that's found in the body, and it works by breaking up blood clots. And so if we suspect someone is having an ischemic stroke with a blood clot, we can give them this medication. It works by breaking up that blood clot, hopefully, and restoring blood flow to the brain. And so once again, this was approved in 1996, so it's been around for quite some time. Now, it only is approved out to about 4.5 hours from symptom onset. The reason being is because after that, it hasn't been shown to be effective. The damage has been done, the stroke has already occurred. Giving that patient a blood thinner like that or a clot-busting medication would only do them more harm by potentially increasing the risk for bleeding. And that is, of course, the biggest risk of this medication is bleeding. The risk is about 5 or 6%, so it's not small. We don't use it for very mild strokes that are non-disabling, but for strokes that cause significant symptoms, we would use this medication. There is a new medication, and it's actually not a new medication, but it's a medication it's been around for a while. I think they use it in heart attacks and things like that. It's called tenecteplase. And it's actually more effective. It looks like it's more effective at breaking up those blood clots. It's given as a one-time bolus rather than an infusion. I think the future is going to be switching over from the TP or the Alteplase on the right over to tenecteplase. The problem with it is more of a schematics kind of thing, is that this drug is a generic drug because it's been around for a while, and nobody is willing to spend the millions of dollars to do these tests, or because nobody's going to recuperate these costs. And so there are some small studies that are being done, and I think that the industry is in the process of kind of making that transition from TPA to tenecteplase. And some facilities that I've worked at in the past have made this switch to tenecteplase, just another IV medication that we can use to treat the stroke. Now, there are also some interventional treatments. So these clot-busting medications, while they're very helpful, they don't always work. And so you can see this CT angiogram on the bottom left here. And once again, this patient has a clot. This is the middle cerebral artery on the left here. Once again, these images are reversed. And this is the right. And so you can see this artery should be coming here and supplying blood to the right side of the head. And here on the left side of the head, this is blocked. A left middle cerebral artery stroke is devastating. This patient would be, hemiparetic on the right side, not able to move their right side. The speech centers of the brain are on the left side of the brain. So this patient would be profoundly aphasic, either not able to talk or stumbling over their words or not able to understand. And so this patient would be, extremely, extremely disabled. So we can give this clot-busting medication, but unfortunately, a large vessel occlusion like that, a large blood clot, the medication may not be effective at breaking up that blood clot. So we can actually have our interventionalists go in and try to suck that clot out. So once again, just like they did with the angiography, they'll take that catheter, that guide wire, direct it right up to that artery using fluoroscopy and imaging techniques, figure out right where that is, and then they've injected this catheter right up to where that clot is. And there are several FDA-approved mechanical devices that will try to pull that clot out. Here you see a stent retriever. They'll go in and kind of put a little stent on that clot and try to pull it out. They have some aspiration techniques that can actually kind of suck it out. They can inject a little TPA right into that clot. So this is very, very effective at getting those blood clots out. The issue is it doesn't work for small. You can't get that into the smaller arteries. In addition, this is a very, very specialized procedure. I think here in the Springs, I know here at Centura, we do it at Penrose, and I think Memorial does it as well. But you need to have the specialist in place to do that. And so as a neurologist, I don't do that. Our neurointerventional radiologists are capable of doing this. But so these patients need to be taken to the right facility. It's not uncommon that patients will get transferred to our facility from outside smaller facilities that don't have this capability. Okay. What about a hemorrhagic stroke? So we've been talking primarily about ischemic strokes. And here you see kind of on the bottom left, or on the bottom, is a diagram of an aneurysm. So an aneurysm is a bulging out of the aneurysm. So with hemorrhagic strokes, obviously we're not going to give them clot-busting medications. The goal there is to figure out what caused the bleeding, stop the bleeding. We drop their blood pressure significantly down to try to prevent that blood from getting worse. We'll reverse any clotting disorder. Maybe they were on a blood thinner for some reason. We'll check their clotting, make sure that they're not having any clotting disorder. And then possibly surgery to correct that. If it's an aneurysm, there's several techniques you can do. Historically, the only thing was available was going to put a clip on there. And they can still do that, and some aneurysms are better treated with a clip. But now we have the ability to go in there and insert coils into that aneurysm. So actually metal coils that will cause that aneurysm kind of just clot off and just become dead, if you will, and will prevent it from rupturing. So you can see here's a little diagram at the bottom where they've actually gone in and put coils in there. And then this is an angiogram where they've done that same thing. You see this very large aneurysm here, and then after it's been packed full of coils. So one of the ways to treat a ruptured aneurysm. Now, primarily, so once we've treated the acute stroke, figured out the cause of it and what we can do to prevent a stroke, really the stroke here is primarily based on rehabilitation. So how can we get these patients better? How could we get them back to where they're doing the kinds of things that they want to do? So while in the hospital, the patients are evaluated by our therapists, our physical therapists, our occupational therapists, and speech therapists. They're figuring out what the patient's rehab needs are, and are they able to participate in rehab? So post-stroke rehabilitation may be in an acute rehab hospital if they're able to participate and if it's necessary. It could be at a skilled nursing facility, outpatient rehabilitation, or home with home therapy. It really just depends on what the needs of the patients are and what the capabilities of the family are. Speech therapy will help patients with obviously speech and swallowing issues. Physical therapy will help patients with movement, ambulation, coordination. Occupational therapy is primarily activities of daily living, cleaning, cooking for yourself, and eating, drinking, bathing, those kinds of things. Now, stroke symptoms, we'll see oftentimes dramatic improvement within the first 2 or 3, 4 days in the hospital, but the real vast majority of improvement is going to come over weeks to months to even out to a year out. You will still continue to see improvement in the function of patients. Beyond that, the brain has kind of done its best to heal up. Beyond that, any improvement is going to be patients' ability to adapt to their new deficits, if you will. So what are the long-term consequences of the stroke? Well, strokes are all different, and the symptoms that patients experience from a stroke are really going to depend on what part of the brain is affected. And so some patients may have paralysis or weakness, difficulty walking, lack of fine motor control, may have cognitive or memory issues, problems understanding or forming speech, trouble controlling or expressing emotions, a numbness or kind of what we call paresthesia, strange sensations in part of their body. Pain in any part of their body, really. Trouble with chewing or swallowing, problems with bladder control, depression. So once again, any neurological symptom can be caused or affected by a stroke. And not every patient is going to have these symptoms. The other thing too is when patients have a stroke, their stroke symptoms are the worst right at the beginning. They don't continue to get worse over years to months. They actually do just the opposite. They get better. And so if someone's had a stroke and their symptoms are getting worsening, that's an indication that something needs to be done to figure out what's going on. So what are the stroke risk factors? And this is the part of the talk, over the next just a couple minutes, we're going to talk about what are the things that you and I and we can do to prevent strokes in ourselves and our family members. So what are the risk factors, the preventable risk factors for having a stroke? So high blood pressure. High blood pressure is a leading risk factor for having a stroke. And so what happens is the high blood pressure over time damages the arteries that supply blood to the brain and to the rest of the body, and that that damage to the artery will cause the blood vessels to narrow down. So high blood pressure is the number one risk factor for having stroke. High cholesterol. So high cholesterol will cause increased atherosclerosis. So high cholesterol, the cholesterol can build up in the arteries themselves. You get atherosclerosis, will cause the arteries to further narrow down and increase your risk for them being blocked off. Heart disease. So, we talked about heart disease, or stroke being the number 2 leading cause of death. Well, the number 1 leading cause of death in the United States is heart disease. The risk factors for heart disease and stroke are synonymous. So if you're treating one, you're treating the other. But coronary artery disease, all that is atherosclerosis, blockage to the arteries in the heart rather than blockage of the arteries in the brain. But it's all the same risk factors: high blood pressure, high cholesterol. Diabetes. So diabetes can further damage the ability of damage the arteries and the ability of the body to recover. Obesity. Obesity is linked to high blood pressure, diabetes, and high cholesterol. So they all go hand in hand. Here you just see kind of a little diagram of atherosclerosis. So you see this artery lengthwise, and then you see a cross section of the artery. On the left, that's what an artery is supposed to look like. You develop a little bit of atherosclerosis because of high blood pressure or high cholesterol, diabetes, or a combination of such. With time, that cholesterol can increase. It gets bigger. And what happens is these plaques, these atherosclerotic plaques, they can actually rupture. They rupture, and it causes the blood flow to become turbulent, and a blood clot forms right there where it ruptured. So on the far right, you see a blood clot that has adhered to that plaque. And so it's not just that the artery gradually narrows down, and then goes away. It's that artery, that atherosclerotic plaque can rupture, and you can develop a blood clot right there. So what are some lifestyle choices that we can all make? And these are difficult. I struggle with these myself, but eating a diet high in saturated fats, trans fats, and cholesterol has been linked to stroke and heart disease. So what can we do? So you've heard this Mediterranean diet is the best diet for the heart and the brain. And you read a lot about these diets, and I've over the years I've read a lot on different diets, and I'm definitely not a nutritionist or anything like that. But I think one of the problems that when we focus on these diets is a lot of these diets will focus on one thing. They might focus on weight loss. Sure, that's weight. That's a good thing to focus on, but they don't really focus on the overall. They might focus on one aspect of the diet. Oh, this diet's good because you eat a lot of fish, or this diet's good because you eat a lot of olive oil, or things like that. But the Mediterranean diet is more of a Mediterranean lifestyle. They eat a lot of fruits and vegetables, whole grains. They don't actually eat a lot of meat, and the meat that they do eat is some of what we would call the healthier meats, the less fatty meats. And so what can we do? We can eat more fruits and vegetables. We can avoid highly processed foods. Eat meat and meat products sparingly. When we do eat meat, we should limit our portions and choose lean options. So I'm not saying that we need to go out there and be a vegetarian. I'm not. But we can do ourselves a favor by choosing the meats we eat, and then also supplementing that with a lot of fresh and healthy foods. Regular physical activity is wonderful for all of these things. Obesity, high blood pressure, high cholesterol, diabetes, regular physical activity will lower your chances for stroke. So improve our diet, improve our physical activity. Too much alcohol raises blood pressure levels and increases your risk for having a stroke. Science say women should have no more than 1 drink a day, men no more than 2 drinks a day. Tobacco use, of course, we all know the risks of tobacco use, but it just exacerbates that for stroke. Yeah, this is it right here. I'm gonna wrap this up and send it off. So the goal for today's discussion, we're going to recognize the signs and symptoms of stroke. I hope we were able to recognize that. Really, any sudden onset of any acute neurological symptom can be a stroke. Know what to do if you suspect someone is having a stroke. Really just call 911, get that patient for emergency medical treatment. And if necessary, commit to making changes in our lives so we can help prevent stroke. Really, diet and exercise is the number one thing that we can do. All right.
Thank you so much. Very informative. We really appreciate it. I want to present you with a certificate for coming to speak to us with our service above self.
Thank you.
And then also a nice little glass to
thank
enjoy your favorite beverage.
Thank you.
And remember us. And don't forget that you've got to get your reservations in for flight on this Monday. And we look forward to seeing you at all the fun things that we're doing. And if you can bring anything for the place for donations, bring them next week. Cody will be collecting those. And I look forward to seeing everyone next week. The meeting is adjourned.